During the surgery, our goal is to maintain euvolemia. There are two restrictive and goal-directed fluid therapy. In restrictive therapy, balanced electrolyte solution or ring lactate is usually given 1 to 3 ml per kg, but there is no preload for neuraxial block or induction of drop of PP due to induction, even no replacement for urine output, insoluble loss, or third space loss. You increase the fluid as requirement, and fluids must be warm to maintain normothermia. But the other major surgical procedures where A-line is done, and there is expectation of more than 100 blood loss or use transshipment of fluid, goal-directed fluid therapy is advocated, where 200 to 250 ml of crystalline solutions are boluses are given based on dynamic hemodynamic parameters. These are newer terminology to maybe to some of you. I'll show you a picture later on. Modern machines, cardiac monitors has this stroke volume variability or systolic pressure variability, and also from pulse oximeter, pulse pressure variability can have an impression of what is the situation there. Both zero or goal-directed fluid therapy is better than liver fluid administration. Excess crystalloid load can cause tissue edema and adverse outcomes. Glycemic controls is also liberal, 7.8 or 8 to 11 in both diabetics and non-diabetics. Aggressive control is to be avoided. This is a arterial waveform, pulse pressure max. From the differences, they can calculate, the monitor can calculate systolic pressure variability. And if it is, say, more than 10, then you need to transfuse volume. This is another way of judging the volume responsiveness to guide fluid therapy. The Frank-Starling curve, you can see, this is the volume responsive part when the stroke volumes is delineated in a congested way by reducing the speed of the graph. So this will be a responsive one. This is volume response. And in comparison, this will be the apexes of the stroke volumes are almost in equal height. That means there's low respiratory variation, and here there is high respiratory variation with increased venous return during inspiration. So this is the low responsive, volume responsive. You need not to transfuse or infuse. The other way in technically difficult, but in higher centers, they are using transesophageal echo to assess the ventricular volume. See how this is hypovolemic and this is normovolemic. So they measure the end diastolic diameter or end diastolic area of the ventricle, and then can calculate the volume requirement. The other common thing then we can do in our ultrasound machines that we are using for giving blocks is the volume of the inferior vena cava. So they will measure the variability of the breadth of the inferior vena cava, and then decide volume status.